We can start and we can always.
Yeah, look, so let's get started. So thank you and welcome everyone who has joined us so far for what promises to be a very exciting session on quite a new topic and something that has excited a lot of interest in the last couple of years as a major advance in the management of patients with chronic kidney disease. All of us have known forever that anemia is one of the most common and most problematic complications of chronic kidney disease. Anemia is in chronic kidney disease is both underdiagnosed, its consequences are underappreciated, and of course, its management has always been suboptimal, in my opinion. I have personally thought that anemia is one of the most consequential symptoms, which, if properly managed, will lead to a lot of improvement in the quality of life of patients with chronic kidney disease, both those who are on dialysis and those who have not yet started dialysis. Now, in the last few years, the advent of HIF-PHIs has marked a major advance in our ability to introduce a new treatment option for patients with chronic kidney disease who were until recently limited to receiving erythropoiesis-stimulating agents, erythropoietin, darbepoetin, Mircera, etc., along with, of course, correction of iron deficiency and so on. In particular, the ability to give this in the form of oral tablets and the lack of requirement of cold chain is a major attraction. But of course, it hasn't been without its pitfalls. And so that's the reason we are here this evening to have a discussion about the use of HIF-PHIs. And just to make sure that the session remains interesting, it has been sort of worded in an exciting and interesting manner. And we will use this hour in the form of initially a debate followed by a panel discussion. And the topic of the debate is that if I had CKD, I would not want HIF-PHIs for treatment of anemia for myself. And we have two really very distinguished nephrologists with several decades of clinical practice experience between the two of them. And of course, they also have fully engaged with the scientific debate on this topic as well. So first, I would invite Dr. Dinesh Khullar, who is the chairman and the director of nephrology, a very, very old friend, to give his perspective for the motion, in the sense that he would be arguing against HIF-PHIs. And his presentation will be followed by an opposite point of view from Dr. Urmila Anandh. But first, over to you, Dr. Khullar.
Thank you very much, Professor Jha, and it's really an honor to be talking on this very important subject, as you have said. And when you introduced me as having decades of experience, I think those decades began with both of us, you being my mentor and senior at PGI, inaugurating and releasing the first erythropoietin of the country by the name HEMAX, and that was during the APCN conference, Asia Pacific Congress of Nephrology, at Delhi between 6th and 9th of December 1992, just about 3 years after erythropoietin had been launched in the world. And we were quite excited because till then we were all struggling to take care of the nagging symptom of anemia in our patients, always relying on blood transfusion, then still the quality of life was not as good. And we suddenly realized we had a game changer, and that was in the form of erythropoietin. Well, over the years, we realized that are my slides visible? Yeah, they're moving as well. Yeah. So what we need to remember is that anemia is associated with increased risk of end-stage kidney disease, cardiovascular events, and death, and that is why we were so much interested in taking care of this. But what have we learned in the last 35 years? We acknowledge the fact that they had well-proven efficacy in hemoglobin correction and its maintenance and avoiding repeated blood transfusions. But of course, a few years later, some safety concerns were raised, and especially these were related to the high doses of erythropoietin and probably setting very high targets in front of us. And these were typically via the normal hematocrit trial, the COIR create treat, which told us to be wiser, not to aim very high. And the one thing is very clear, that more than 13 grams of hemoglobin achievement is harmful. And this was also reiterated by this very large systematic review, which concluded that high doses of ESAs were independently predicting cardiovascular mortality and all-cause mortality. Increased risk of cardiovascular mortality with high doses could be seen compared to the basal doses, and it's advisable to go in for minimal possible dose of ESA. And this is the way we have evolved. We initially thought high is better, then we realized high is worse and high is worse. And this is what probably the new draft up for grabs at the moment for the upcoming KDIGO guidelines is also going to say. What we have now been focusing is to keep a hemoglobin level of as close to 11.5 as possible. So there have been challenges with ESAs, because the topic given to me is, given a choice, if I were to receive, which one would I go in for? Obviously, it is not to say that I don't like HIF-PHIs, that means I receive nothing. So obviously, it means that I am going to fall back on something which has been available to us for the last 35 years or so, and 32 years in our country as well. But there have been problems and challenges. One of them being ESA resistance. We find that 20% of people do not respond at all. And this ESA hyperresponsiveness is because of various conditions, including inflammation. And that is when we realized the role played by hepcidin. And we were trying to figure out how to take care of hepcidin over the years. And now, hopefully, we are much wiser. We'll come back to that. And equally important is the hemoglobin variability, where we know that if we play around with the dosages too much, it is going to cause this kind of variability, is going to cause ventricular hypertrophy, heart failure, and other organ failure as well. With this background, let's talk about the optimism which has been brought in by the hypoxia-inducible factor prolyl hydroxylase inhibitors, a new class. But whether it can really address the challenge of ESAs, or should we really comment about them, about their efficacy and safety right now, or wait for the long-term data? So let me make Dr. Urmila's talk a little easier, so that he will have more time to discuss about so many other things, which I'm sure she's wanting to today. But just a recapitulation of the way the HIF-PHIs work. And in normal oxygen conditions and normoxic conditions, the prolyl hydroxylase domain, the dioxygenases, they degrade HIF alpha, and the HIF alpha is presented to taking the help of the OHDDs, especially via the AKG, the alpha ketoglutarate pathway. It is presented to the von Hippel-Lindau protein, and the sauce is typically engulfed. There is ubiquitination, and finally proteasomal degradation which takes place, so that HIF alpha is not able to go into the nucleus and cannot get dimerized and start the gene transcriptions. But what is important to remember is this: not just the low oxygen, as you can see here, it's low iron as well. High phosphorus is what is also responsible, and then comes the new the new molecules, that's the HIF-PHIs, which can have the role. But look at what they do. It is not just about one particular gene, the wanted gene, which they transcribe. They also bring in a whole lot of unwanted things. As you can see here, erythropoiesis, iron metabolism are the good things which we want, but we don't want so many other things, including, as you can see here, the ones which cause proliferation, the one which bring in cancers via angiogenesis, the mutagenesis, and then of course the proliferative retinopathy, which can be seen with the bringing in of VEGF. Now, important things, and why I'm not happy being given HIF-PHIs if I were to receive them. Let me take you back to where we all have started to know about HIF pathway. The HIF pathway, this is where it begins. Alpha ketoglutarate, as you can see, is going to take care of the prolyl hydroxylase domains. Now, what is important to remember is this belongs to a group of enzymes called 2-OGDDs, And these are going to ultimately take care of so many of the downstream pathways. But what is equally important to remember is that there are some reported health protective effects of AKG. That's it has anti-aging property. It has a healthy lifespan extension properties, anti-osteoporotic, anti-inflammatory, anti-carcinogenesis, and pressure overload cardiomyopathy protection. So you can imagine we basically are wanting to have AKG with us. And what happens is, now, as you can see, it's in the center of a wide range of physiological processes. And where should HIF-PHIs ideally act? Now, I'll take you to some very interesting phenomena. This is where we want them to act. That's the PhDs, and not early, not upstream at the level of AKG. Now, what is happening is, where exactly do they act? They are acting at the level of AKG. Let me. Now, so they are acting here rather than acting here. And so obviously, if you take away AKG, you are going to have a loss of all those great effects of AKG, which we have known over the years. Now, these protective effects are gone. So far, let's see what all the HIF-PHIs clinical trials have shown us. Now, CKD patients not on dialysis, these are the various trials with roxadustat, and assessment was done at 28 to 52 weeks. What they inferred was there is period to placebo. Well, not a big deal. Non-inferior to ESAs. All this while we were talking about that this new class is non-inferior to ESAs. And basically, initially talking about a theoretical superiority, and now we were talking about just non-inferiority. So that's for the patients on dialysis. Now, another thing which is very often linked with HIF-PHIs is their effect on hepcidin. So let me bring out this point. Are they really targeting hepcidin directly? The answer is no. So here, as you can see, they increase the endogenous plasma and erythropoietin production, which now will go to bone marrow, cause erythroferron production, and is basically erythroferron, which is inhibitory to hepcidin rather than HIF-PHIs having a direct effect on hepcidin. Now, this kind of effect, the pleiotropic effect, is also seen with some class of ESAs, especially darbepoetin. So why become so excited about the fact that they have a tremendous effect on hepcidin? Well, if that was the case, I'm not denying the fact that that's important. We have struggled to find an antidote to hepcidin. But the effect here, as I've shown, is via erythroferron and not a direct effect. Now, the important thing. So far, we have said there is nothing wrong with HIF-PHIs with whatever limited data over the last 3 or 4 years, the last 3 or 4 of real-world evidence. But may I ask this question? Does the absence of evidence of serious adverse events with HIF-PHIs mean evidence of absence of serious adverse event, and that too so soon, just about 3 years? We all know things like angiogenesis, things like oncogenesis are going to take years. So we cannot be complacent as far as at this point in time is concerned. All the trials were mainly powered to prove non-inferiority for the hemoglobin change, and that is something which we have always to bear in mind. Now let's look at what the safety data has shown in patients not on dialysis. As you can see here, in ASCEND-D, hospitalization for heart failure, cancer-related drug, esophageal or gastric erosions, retinal disorders, acute kidney injury, all were at least numerically increased in number. But definitely there are some safety signals attached to this. Now, this is about patients on dialysis, not on dialysis, and now coming on to patients not on dialysis. So, well, as you can see, with roxadustat, you could see deep vein thrombosis, pulmonary embolism in patients. With vedadustat, there was the issues with cardiac failure, congestive cardiac failure, and this is in comparison to darbepoetin. Well, the PROTECT 2 is important. It did not meet the non-inferiority margin. So these have been, as I said, been the safety signals, and that is what scares me to directly go in for such a therapy, at least at this point in time. Deprudustat and heart failure. Now, this is very interesting, as I would like to draw your attention to this particular panel here. The first and the recurrent heart failure hospitalization. Look at the difference between deprudustat and the red line and darbepoetin as a comparator arm. So again, the risk relative risk was 1.46, a 46% increase. Well, as you can see here, the initially what the company was talking about was non-inferiority in MACE in intention to treat. But FDA said we are not interested in intention to treat. Tell us about what is the treatment analysis. However, the treatment analysis has revealed increased risk with deprudustat, and that is why the FDA has not approved deprudustat in non-dialysis patients. Talking about the CKD patients on dialysis, again, there has been issues with proliferative retinopathy, macular edema, choroidal neovascularization, and in deprudustat as compared to darbepoetin, increased risk of non-fatal stroke. Although the numbers may be not very significant clinically, statistically, but then at least numerically, definitely a safety signal. And with others, the case was no different. So, and when you look at the CKD patients already on dialysis, there was an increased chances of AV fistula thrombosis. Risk of death at 18 months was higher in patients on roxadustat as compared to the placebo in the erythropoietin arm. Well, the AV thrombosis was also seen in other trials as well. So similar kind of safety concerns were shown in all of these trials involving the various HIF-PHIs. Well, this is something very interesting. Roxadustat came out with a statement that the use for CKD-related anemia is actually a good thing. So what they tried to show was that roxadustat had 30% low risk of MACE, 34% low risk of MACE plus, but later on, they retracted from the journal due to discrepancies in the results, which FDA had picked up. So the retracted notice to pooled analysis of roxadustat said that for patients in anemia, so this is being retracted. So looking at the long-term efficacy and safety, this is another article which looked at the thrombosis events. Look at this. Almost like 31% risk, relative risk increase with the use of HIF-PHIs. So there is a trend of increased risk with HIF-PHIs, as you can see here, especially related to the MACE, deep vein thrombosis, pulmonary embolism, heart failure, retinal-related adverse events, cancer progression and related deaths, AV fistula thrombosis, hyperkalemia. So definitely, I would say it's too early to comment on long-term safety of HIF-PHIs because everything written on the left-hand side are the theoretical risks. And obviously, these molecules will have to be perceived as safe enough for a number of years before we can say, yes, we are ready for them. Not at this stage, certainly. The clinical superiority, as you can see here, could not be shown via HIF-PHI. So they really could not keep up to the promises which they had made initially. The physiological EPO levels would reduce the off-target effects of supraphysiological EPO levels with ESAs. And well, the answer again is no, because the MACE worsened in trials. They also said that maybe reduced IV iron requirement would be there with HIF-PHIs. Well, how far will it translate into clinical benefits is yet to be seen. And again, another thing which they said was reduced LDL cholesterol with HIF-PHIs could be compared to ESAs. And did it reduce cardiovascular events? The answer is no. At least we don't have data which is pointing towards that. Well, US FDA has certainly raised safety concerns regarding HIF-PHIs. About Roxa, it declined to approve it. About Vedada, again, the similar kind of story. With Deprudu, they could only approve it in patients on dialysis and not patients not on dialysis. So why are we really worried? And there are definitely at least theoretical mechanisms behind these off-target adverse effects with the HIF-PHIs. And what are these? Talking first about the HIF and cardiovascular system. As you can see here, HIF can regulate the cardiovascular system, and what you can actually encounter is pulmonary hypertension. So it's a contraindication. If your patient has idiopathic pulmonary hypertension, you would be wise enough not to use them. Thrombosis, atherosclerosis. So this is about cardiovascular system, but why do they increase thrombosis? As you can see here, the HIF now, because of its lack of dimerization, the HIF1 is there. So that increase causes activation of plasminogen activation inhibitor and the tissue factor, and there is a suppression of tissue factor production inhibitor. So all these things added on to the fact that the protein kinase B phosphorylation takes place, which has an effect on the platelets and monocytes, will all combine to cause thrombosis in a patient. Why do they cause heart failure? As you can see on the left-hand panel, normoxia allows the ATP production in the cardiac cells as well. While when you create hypoxia or you give HIF alphas, the aerobic to anaerobic cell will produce the cycle will produce more of lactate from pyruvate, and you know lactate is not a good news for our patients. There is a lack of production of ATP, so there is the source of energy for the cardiac muscles is gone. So that is why the risk of heart failure definitely is a distinct possibility. How does iron deficiency cause it? Well, you know that in the presence of iron deficiency, as shown earlier as well, there is a chronic activation of HIF. We don't want a chronic and a permanent activation of HIF via either hypoxia or HIF-PHIs uses, because a persistently elevated HIF is a bad news. It will cause FGF23 increase, risk of calcification, thrombosis, and heart failure. All these are distinct realities. Chronic hyperphosphatemia. Now, normally, whenever there is an increased phosphorus, it causes an increase in HIF. So that will cause an increase in FGF23 and get rid of the phosphorus. While what we know is in patients with more advanced chronic kidney disease, FGF23 will not be able to have its effect via clotho, and at the level when there is a persistently elevated HIF, the FGF23 can play havoc via vascular calcifications and cardiac hypertrophy, etc. Now, shifting gears, HIF alpha can also cause renal cyst expansion through the calcium activated chronic chloride secretion. So one should be very, very careful using them in a patient who has multiple renal cysts till the time safety concerns are ruled out. Well, this is something which is something very dreadful. If any class of drugs is actually going to cause an increase in mutagenesis, oncogenesis, obviously, this is something which I personally would not like to be used on myself. So this is what you can expect when HIF alpha, 1 alpha and 1 beta, they dimerize. You can expect not just erythropoietin production, but also angiogenesis, invasion, metastasis, cancer stemness, and metabolic reprogramming. So again, so the risk is definitely there, and we will need years before we can say, well, probably these fears were unfounded. As you can see, a whole list of events which can cause vascular calcification in these patients. But then look at this. There is a HIF alpha, HIF-1, which is one of the molecules which can perpetuate vascular calcification. So again, the bad news for our patients. Well, HIF activation, as was shown in this study, promotes osteogenic transition of valve interstitial cells and accelerates heart valve calcification in chronic disease patients. Again, a very issue of serious safety concern. So the ERBP 2024 guidelines give us a caution. They say, use these drugs with caution, especially if your patient has vascular excess, thrombotic complications, retinal disorders, autoimmune diseases, history of cured malignancy, and a kidney transplant recipients, because we don't have safety data in them. Avoid or use with extreme caution in patients with cardiovascular or thrombotic events, history of malignancy in the previous 5 years, polycystic kidney disease, untreated and a significant proliferative diabetic retinopathy, idiopathic pulmonary arterial hypertension, and the key points are you must ensure that you have the basic knowledge of when to use HIF-PHIs. So this is a sneak peek. I know I'm not allowed to talk at length about what is not there, but these drafts are in the public domain for scrutiny, and they also, I'm not saying this is a final word. This may get changed, but at least what we know, what is going on in the wise men's minds is that in people with anemia and CKD in whom correctable causes of anemia have been addressed, we suggest using an ESA rather than a HIF-PHI as the first-line therapy because of the various reasons as have been enumerated. And this is what they are talking about, that use with extreme caution or probably not at all in these patients, which I've already alluded to earlier. So to end now, this is a very nice debate which was there sometime back between Dr. Vish and Ajay Singh, and there were pros and cons. The way I'm pitted against a stalwart like Dr. Urmila Anandh today. So ESAs, as have tried to reason out, are the devils. If they are devils, they have their shortcomings. Are the devils which we know about, we know more about, especially as far as these concerns are there. While the HIF-PHIs are the devils which we don't know much about. So we'll take a number of years before we really master the art of best using HIF-PHIs. Till then, I'll not want my doctor to use HIF-PHIs on me should I get anemia related to CKD. So to conclude, I'm reminded of my English grammar classes where I would always try to say and try to remember these past perfect. And now I believe in the context of what we are discussing today, past perfect nahi hai. Present tense, yes, present tense hai. As you can see, I'm at least quite tense. This is what I'm going to thrown at by Dr. Urmila. And future indefinite, at least to my mind, lagta hai. Well, Dr. Urmila, so this is something which these stalwarts often have to face the criticism, no matter how good they are. But so many times we find them facing the criticism. But at the end of the day, let me remind you, we are both in the same team. No matter how our adversaries try to create a rift between us, try to pit us against each other, we'll remain friends because we are both in the same team, trying to take the best possible care of our patients suffering from chronic kidney disease. Thank you very much.
Well, thank you, Dr. Khullar, for making such a spirited argument in favor of the motion. You have really sort of raised the bar, which Dr. Urmila Anandh now has to clear. But I'm pretty sure that she'll do it with aplomb. Both of you might be in the same team, but it's like IPL. You have to play for different teams. So over to you, Dr. Anandh, to give a fitting rebuttal to Dr. Khullar.
How do I share my screen? Sir.
The bottom, you have a share button,
Yeah.
green button.
Yes. Thank you. Thank you, Professor Khullar, for this 15-20 minutes of HIF-PHI. And I am here as a patient, not much of a doctor knowledge. And I realized there were lots of cartoons, lots of names, ABCDs, and a lot of, what do you say, theoretical slides where you actually defended your case by not saying anything good about ESA, but all that is going wrong with HIF-PHI. I will try to see to it that as a patient, what are the benefits that I have as HIF-PHIs, and we'll try to look into the inconsistencies of that you had said, because there were times when you said the dimerization between HIF-alpha and HIF-beta is not good. In certain pathways, they create problems. But then there was a slide where I remember where there is no dimerization, that is also not good. So ये HIF-PHI वाले करे क्या? Dimer भी नहीं बन सकते, ना dimer भी बन सकते हैं. So I realize in your slides there have been two, and those are all physiological mechanisms of going against the drug. And also in your presentation, it was mostly about FDA, the United States, and the KDIGO. They don't make up the whole world, and their challenges and our challenges are different, which actually makes these drugs little useful in clinical practice for us. And you also discussed more about data. I'll get back to it. The only way we can get data if patients like me actually use this drug, then only we'll have the data. So I move on. So you and me come from the pre-HIF-PHI era. In fact, when I joined, as Dr. Vivekanand Jha sir was saying, we just had ESAs in our armamentarium. And in the HIF-PHI area, what would have been used for me? ESAs, iron supplements, and even blood transfusions. I would definitely not want a third concept. So now what do I have? I have ESAs, which has been used with us from 89, so almost 35 years in practice. Now I have this new good drugs which are oral, and we have lots of iron. What Dr. Khullar did not say that the management of anemia is just not these two drugs, but the use of iron in our practice. So the iron metabolism makes a important sort of part of our armamentarium in managing my anemia. And that therein lies the major catch for us, because it's easy for me to take injections, which is not. But handling iron, either orally or injections, is going to be a challenge, especially I've not got into dialysis as yet. So this was what Dr. Khullar had said. This is from the ERPP guidelines, NDTP. And then that is where he said that these are all transcription factors which, when they enter the nucleus, get dimerized and lead to the, production of erythropoietin. And this erythropoietin is actually a physiological erythropoietin, not some injections which is made, and there are many forms. Some of them are attached to pegylation, some of them have long acting erythropoietin. These are not injections, this is the manipulation of our pathological, our physiological pathway in a response to iron. So we just don't produce EPO, we also modify erythropoiesis by many other physiological pathways by improving EPO receptors, EPO production, iron metabolism. I agree, HIF-PHIs are not involved in hepcidin, but it is involved in iron absorption genes and iron transport genes. These two things are very important. And if you look into KDIGO, they have actually used the word iron restriction, not as a functional iron deficiency now. So it is very important that we know that just not giving an oral tablet, but we should pari passu see to it that the iron metabolism is maintained well. And Professor Khulla, chronic iron deficiency is much more commoner with ESAs rather than with these, because they metabolize and use iron. That's one pathway that where we postulate theoretically that the iron levels will come down. But our concern of iron deficiency in real world practice is the use of injectable irons and drugs which create a lot of gastrointestinal symptoms. So patients with ESA actually have more chronic iron deficiency. And I agree with you, chronic iron deficiencies, which actually will activate your HIF-PHIs. So there are many DOSTAT. Sir has mentioned all of them. This is the one where there were a lot of issues with FDA because they had to retract papers. And this is what we have now from 2021 after the roxadustat issues. And now it has shown that it maintains hemoglobin and it is non-inferior to darbepoetin alpha. The word non-inferior is because the study designs have been non-inferior. And there are many parameters which has not been sort of factored into. The dose of darbepoetin, the frequency, the current iron levels, and of course the dosing of roxadustat. Sir kept on saying that we should not increase the hemoglobin to more than 12. That is true for roxadustat also. And the issues with many of this MACE is because these drugs, we are now getting our feet wet with these drugs, and we realize these drugs actually increase the hemoglobin level a little faster than ESA. So we need to learn and we need to temper our judgment, clinical judgment in as to how to use these drugs, and do we need to give them alternate day or in different dosing. So this is about roxadustat. What we have in our country is this drug, which has undergone phase 2 and phase 3 trials from many of our colleagues from India. And both of the studies have maybe non-inferior, but they improve the hemoglobin. The hemoglobin rise is seen within 4 weeks. It maintains the hemoglobin for a longer period of time. The studies have been for 16 to 24 weeks. So the hemoglobin variability is less with these drugs. And with placebo, yes, there are benefits. And the side effects also have been mentioned in this study. And so what is important that it mimics the body's response to hypoxia. And if the response to hypoxia is to improve EPO production, I'm sure as we correct the hypoxia, the negative effects of hypoxia will have a pleiotropic effect for the whole body. They improve EPO receptors, no chemicals being put into your body. the body itself upregulates these receptors. This HIF-PHIs are involved in genes in transcription of iron absorption, iron metabolism, mobilization, and not just mobilization, uptake into poor erythrocytes and RBC maturation. The hepcidin production is reduced because of its mobilization effect and its so-called anti-inflammatory effect. What is important to know, in both the DREAM-D and DREAM-ND study, these drugs were quite effective in patients with high ferritin and high CRP. And whatever we may say and whatever we may do in real world practice, this group of patients are very, very common in our part of the world. So what is important for us is the challenges of management of anemia. We don't go into all the other effects of the cellular effects of this drug. For us as a nephrologist and for me as a patient of CKD, managing anemia is more important. I'm not bothered, or I need this to be addressed. And as Dr. Vivekanand Jha said in the beginning, anemia, a low hemoglobin, is perhaps one of the most important symptom of a patient with chronic kidney disease. So the mechanism of this drug, the use in anemia, is that erythropoietin is a treatment using pharmacological agents. Whatever you say, pharmacological agents have its own disadvantages. Whereas HIF-PHIs actually look into the pathway of the trouble, that why erythropoietin is being reduced in our patients and how can we increase this erythropoietin in our CKD patients. It's just to stabilize the hypoxia individual factors and increase endogenous erythropoietin. So here the flexibility or the variability in erythropoietin levels are lesser compared to ESAs. ESAs, you may, if you do the levels, sometimes you see them to have very low levels. And if you give injections and then you get into a very supraphysiologic level of ESAs. That does not happen with HIF-PHIs because the ESAs are maintained, as we know, in the physiological range. Erythropoietin alpha takes care of your anemia without thinking about iron. And in India and all over the world, iron deficiency is a much more common cause of anemia than anything else. So these drugs actually improve the genes which will improve in iron metabolism and transport. In fact, when you give ESAs, you increase iron utilization. So KDIGO has been always maintaining a TSAT at least 10 points higher for patients on ESAs and patients not on ESA, 20%, 30%, and is going to go up now. And so we have to use iron, and utilization of iron, the iron supplementation is going to be a challenge for us. Whatever Pivotal or FIND have said that iron is safe, but then we are going into looking into study that how safe is maintaining iron dosage to maintain a TSAT of 40%. So then we'll have an issue at that time. So this is the paper from Dr. Agarwal, where he has looked into iron metabolism. I'm just looking into iron metabolism, where I agree with Dr. Khullar, it is just not the HIF-PHIs which will help us in mobilization of iron, utilization of iron, and improving in hemoglobin. The rise in hemoglobin is not just sort of stabilizing HIF-PHIs, but also to get a physiological or a salutary effect on iron metabolism, the second arm of anemia management. He also mentions about hepcidin antagonists, which we'll have to be thinking about in the future. So this is ESAs don't actually, in the conclusion, as is being said, does not look into the fact of iron dysregulation, which is of iron metabolism, which is so common in our patients. So this is from the same ERBP slide, where if you look into it, just how iron physiology is sort of facilitated or improved with all the two stats. If you look into ESA at the end, there are no greens or there are no blues. They're all red. So the iron level, utilization, the ferritin going down, increasing TSAT, increasing TIBC, increasing transferrin with some of the two stats, and consistently reducing hepcidin in studies. Even our DREAM-ND in a short-term study and DREAM-D both have shown, I think DREAM-ND showed a reduction in hepcidin level. How it will translate into a clinical fracture practice, we don't know. It's very important to know that all these studies have not, even ESA use with a higher hemoglobin has shown it makes a difference in mortality. But at 12 hemoglobin, it has not made much of a difference to overall the correction of anemia and its impact on mortality. Now, the next question that bothers me, that I may need my anemia treatment lifelong. And am I willing to take injections frequently? I may not. And if I'm not taking injections for my iron, I may have to take tablets, which have a lot of side effects, which my patients say almost 30 to 50% of them, for whatever form of iron, have some GI side effects. And they don't do much as my CKD worsens in my hemoglobin. So, am I willing to take iron injections? There are side effects. There are theoretical side effects as we looked into HIF-PHI. It's oxidative stress and various other effects of iron. Even though that is the difference, no, sir. In theoretical side effects and real world trials, there is always a dichotomy because high doses of iron, we started with ferritin of 200, 300. Now even 700 is acceptable. So similarly, I hope in future we will sort of junk those various pathways, and as we get more real world information, HIF-PHIs will be used regularly. So besides that iron management, we look into my patient as a patient. What are the advantages of my using HIF-PHIs? Except in hemodialysis, oral treatment doesn't matter. We can give them iron. Some of us have needle phobia, and we cannot administer ESA. And we also know various studies from various parts of the world. Dr. Khullar alluded to almost 20% of hyperresponsiveness, that they go up to even 30 to 35% in inflamed patients and patients with other diseases. And even though whatever we say, hypersensitivity is a challenge for IV iron for all of us. So I would like to avoid using, though the real world scenario of reduction in iron usage has not come in, but the studies have not been designed, especially non-dialysis dependent studies where how much of oral iron or iron requirement has come down. This question has actually not been answered. And there is clinical trial, not just what you presented, sir. There have been meta-analysis, systemic reviews, where after the controversies conference with KDGO, there have been many data have come in forward, which I will be alluded to a little later, where safety has concerns have been addressed to a certain extent. So as we look into the advantages, it maintains EPO within physiological levels, convenience, oral, and I'm a traveler, as everybody knows. I don't want to carry a fridge with me for my injections. Reduces hepcidin, which has been shown in our Indian studies. Cost comes down quite a bit, which I think is a major advantage for us. It really comes down, and it actually, that question of reducing iron supplementation oral has not yet happened, but studies need to be designed to look into this. And the additional safety of pure red cell aplasia, which we don't see. And then there are studies which they have shown acute kidney injury has been reduced in complement mediated kidney damage. So, where that question of progression of chronic kidney disease or AKI resolution has not been addressed in trial setting. So, it will not be nice of me to talk of certain things which we don't know much about. This is one thing which Dr. Khullar, in his nice slide with lots of arrows looking at pleiotropic effects, actually did not mention or did not look into it, the impact of HIF-PHIs on two major lipid metabolic enzymes, acyl-CoA and HMG-CoA reductase. Both were not mentioned, and both of them have been postulated to make a difference in lipid levels. These are data from our patients which have significantly shown the reduction of LDL-C in both dialysis and non-dialysis dependent patients. This is what Dr. Khullar wanted to, and he spent a lot of time on this. So I have just got a little bit of it. This is, and if you look into the top part of my table, first is theoretical risk, second is adverse event from clinical trials, and third is insufficient data. So that is where we stand. This is, I'm not supposed to talk about, this is going to, KDGO may change this, but it is up for public aim. So this is how it has been. So there is all of these are theoretical risk. And there is a box warning about cancer, active cancer, or cancer for last 5 years. But most of them have been theoretical. Pregnancy, of course, we have no data to say about it. Adverse trials, which you have all talked about, central hypothyroidism, bacterial infection, mostly with roxadustat, have been discussed, and data in clinical. There are small studies from Japan where it has been used safely in kidney transplants, but we don't have for in children. So these are the different. These are not what we have data from real world. Some may say intention to treat or to treat data. Intention to treat data and the to treat data was different for roxadustat, but then other studies and other analysis have sort of shown a different effect. This is a phase 3 study on roxadustat on and on eyes. If you look into new or worsening retinal hemorrhage as a group, there is insignificant difference between the two. New retinal hemorrhages, yes, it is higher, but still in both the studies, there is very little risk of increased risk of adverse ophthalmological events. This is about proliferative retinopathy in our diabetic kidney disease patients. This is a study with more than 300 patients. For daprodustat, there was a lot of data, and this is from Dr. Ajay Singh's group, which came out in 2021, where they looked into a large cohort, and they finally said that the major MACE, non-inferiority margin of 1.25, is actually 0.93. So in patients undergoing dialysis, daprodustat was non-inferior to ESA in both hemoglobin levels and MACE. There's a large study and there are many studies. I will not go into most of them because I'm a patient. For me to understand fine print is a little difficult, but I go by what is being presented in literature. And this is with dialysis. This is a systemic review and a meta-analysis which has just come out in 2022 in AJKD, where if you look into non-dialysis, patients not receiving dialysis, all of it, the placebo and ESA, there is hardly any difference. In fact, if you look into HIF-PHIs and ESA, hypertension, a common driver of heart failure in our patients, it seems to be doing better as far as we are using HIF-PHIs, even though the data is not very good. Hyperkalemia in this analysis is not higher than what we thought. Even on dialysis, various other cardiac outcomes are progression to ESKD or dialysis is also not different. So this analysis, which included 23 randomized controlled trials with more than 15,000 patients, actually said the occurrence of cardiac or kidney-related adverse events, the end one, the progression of chronic kidney disease, in HIF-PHI groups were not different compared with placebo or ESA, both ways. So this is being shown in this analysis. And this is the Italian Society of Nephrology guidelines, which they commented upon after the KDIGO controversies conference. And the opinion of the group, they agree with KDIGO conference of this is the controversies conference 2 years back, not the guidelines which will come. That HIF-PHIs are as effective. They have not used superior, non-inferior as ESAs in correcting hemoglobin levels in both dialysis and non-dialysis dependent patient. This has come in 2024, the Italian Society. Now, where they have divergent opinion from KDIGO that there is an accumulating evidence in the last 2 years after the KDIGO conference reports, which supports the non-inferiority of HIF-PHIs for cardiovascular safety. That they have now sort of agreed to, and they believe that we need to move around with our concerns for MACE and look into using these drugs in a rational way. Secondly, in patients of interest, support that HIF-PHIs may be more effective than ESAs for correcting anemia in hyporesponsive patients, a large percentage, a significant percent of patients on ESAs. I may like to start ESA because KDIGO tells me to do it. But then what do I do? After 6 months later, my hemoglobin doesn't improve. So that is a concern that we have. Similarly, the possibility of and frequency of oral iron could be a clinical importance because of the incidence of gastrointestinal side effects. If you look into the most important thing for a patient is quality of life. And both these groups have consistently shown that quality of life compared to each other is no different. But there is no instrument whatsoever which has looked into a quality of life where they have been asked, would you like to have oral medications? Does oral medications make a difference to your quality of life? So that question has not been addressed. And I think we should, when we look for quality of life and when we ask for patients, I was with Dr. Vivekanand Jha in a KDGO meeting. I realized that whatever we were discussing were actually diametrically opposite to what patients wanted. So that is where what is happening. Now, as a patient, I would like these things and I will sort of worry about other side effects later. I need my medicines to be safe, period, and I need them to be used in a way that I don't get into trouble. This is the consistent statement where they have written all the advantages. And if you look into it, the advantages of HIF-PHI is much more than compared to ESAs, only 2 lines. The different the disadvantages are more on the HIF-PHI side, but as we get more data, we will be able to understand this better. So this is what the ERBP guideline, which Dr. Khullar looked into it, where they have looked into the advantages, oral dosing, anemia treatment will improve utilization of anemia, more effective in chronic inflammatory states, and stability in room temperature. Importance is because there are oral tablets, we may not be able to adhere. More drugs, and this word which has been mentioned time and again, and I'm sure the panelists will look into it, that is lack of clinical experience. This is what Sir had written for use with caution from the same paper. Just have to look forward, which he had actually, if he had cut pasted, that's where they have in fact, they have suggested use of HIF-PHI in NDD, CKD, or PD patients. Because for patients' oral treatment, starting ESAs because of injections, adherence may be an issue. In PD and ND patients, even delivering the drug is an issue. For injections, they may not take it themselves and they may not come to the hospital to take the injections. Iron therapy, because if we believe that we start ESAs and iron levels drop dramatically because of utilization, what do? We bring them back to the hospital for IV iron? Do we give them the tablet which they will stop using? And of course, patients who have hyperresponsiveness, they have said. SD patients also, they have said oral treatment. Patients on home SD. There is a small significant percent in our hospital in busy units where hypersensitivity happens. And in fact, because of all these iron issues, the use of blood transfusion has increased over a period of time, especially in our oncology patients.
Dr. Urmila, will you please draw
Finish, sir. This is the last one, sir.
arguments to a
The
close?
last, sir. So this is the sneak peek. I have told, sir. Sir had written there that ESAs may be used for KDGO for first. But then if you look into that, cardiovascular cancer, the same committee says, if there is any cardiovascular issue, withdraw ESA. If there is any history of cancer, you should have shared decision making and we should be stopping it. So what is being used as guidelines, the same guidelines are again saying not to use that. So finally, sir, what we need is more data and we should have clinical decisions. Thank you very much for your understanding.
Thank you, Dr. Anand, for putting the opposite side of the argument with equal vigor and force. Now we'll go into the discussion part. And Dr. Khullar, you have the first right to have a few words, maybe 2 minutes for your rebuttal before we go to the panelists. But please
Well,
keep to the time because we will go a little bit over time, but not too much, I hope.
Well, I thought the topic today allotted to me as a patient was related to HIF-PHIs. What we very nicely heard was something about iron, and thank you, Dr. Urmila, for my revision on iron metabolism and what all can HIF-PHIs do to iron. But I would say, as a user and end user, let me confess, I'm very finicky as a patient. I would first want to know about the safety of a given drug and rather than the efficacy. Yes, efficacy my doctor must know, but I have full right to know about the safety. And all that I was repeatedly trying to point out was the data so far points against it. There has been alerts about MACE, there have been alerts about what it can do to cancer, retinopathy, pulmonary hypertension. I'd be mortally scared. And if I tomorrow also get pulmonary hypertension, I would certainly, from whatever I have heard from my doctors, will not be wanting them to use this on me. You have very conveniently forgotten of a point which I raised. AKG is I would love to have AKG in my body, and you are wanting to take away AKG's positive effects, be it anti-aging, pleiotropic, bone related, and metabolism related. And the moment AKG goes away, I'm going to be deprived of all those things. Now, what is important, and the point I was wanting to highlight is HIF. Bringing back HIF temporarily is good. I accept it, but permanently bringing back HIF is definitely going to be a danger. Please don't do that. There will be my understanding at this point in time till the time we have more data. You were talking about the side effects of IV iron. Let me remind everyone, yes, there are very few side effects of IV iron nowadays, but we are very conveniently forgetting about the side effects of HIF-PHIs if we want to have in the fairness added on to it. Now, you talked about an oral thing. You said you are a globetrotter. You don't want to take injections along with. There are oral powdered formulations of ESA available. Let me remind everyone. You talked about LD effects. Where is the proof that bringing down LDL with HIF-PHIs could translate into something useful as far as their reduction in MACE is concerned? So I think in overall, what we have to accept is, yes, they may be doing something good to the iron, but the guidelines tell me don't be scared of ferritin till 700. There are few people who would want to go up to 1300 of ferritin in the dialysis population. When I have safe IV formulations, and I don't mind taking once in a while IV iron going to the hospital. I'm one of those patients. So I want safety first. My doctor has told me in case you need iron, we have perfectly safe IV preparations. You will go in for that. But he does not tell me that HIF-PHIs are safe enough. I don't want experiment on me at this point in time where
Okay,
3
thank
years
you.
is not long enough.
All right, thank you, Dr. Khullar. I think this is a debate that can certainly continue. But now we come to our two panelists who have been listening to the arguments for and against the motion very patiently. Both of them also have a lot of experience. But I'm pretty sure that they have also been thinking while all of these arguments are made, arguments about mechanism of action, arguments about potential benefits or potential lack of benefit thereof, and clinical trial data. Again, clinical trial data often are interpreted to suit one's own set of beliefs or arguments. But what do you have to say with, and if I might start with you, Dr. Meena, for example, when you look at all of these data, what are the main concerns that you have, and what are the first few questions that you ask looking at all of these before you make a judgment about what will you do for your patient? Now you take on the role of a doctor instead of a patient that our two debaters did.
Thank you for the beautiful discussion. First of all, we should know whether this patient is suitable for not, because we have more experience with the ESA. We know what are the side effects. We have been using it for so many days. We are actually more confident with ESA. But what if my patient can't take ESA? What if my patient comes back to me and say that, ma'am, I can't take these injections. Please give me something else. So what are the alternative I have? Yes, we do have HIF-PHI inhibitors. So if the patient can't take injection, for example, in the CKD 4 or 5, not on dialysis, he can't maintain the cold chain, I would happy to give HIF-PHIs, but also I would be very much stringent in monitoring, because a lot of trials have said about hyperkalemia. I would rather more monitor than hyperkalemia monthly. Initially, I would also be more monitoring about the hemoglobin, because these trials have shown a sudden rise in hemoglobin. I don't want that kind of sudden rise in hemoglobin. I would sustain and maintain hemoglobin. So if I would see if there's a sudden rise in hemoglobin, I would not use HIF-PHIs. I would shift them to ESA inhibitors. In my dialysis patient, I usually do not have problem in the injection. They are happy with the injection. They usually do not complain. But there are many states when the patient is not responsive to ESA. So we have to think for other therapies. There are cases of PRCA, which they have been, most of them are using. We have all seen PRCA cases, so we can use them there. And yes, in the inflammatory state, which is one of the reason for ESA hyperresponsiveness, I can use such kind of agent. But yes, I would be, if I'm seeing any kind of previous history or malignancy history, especially within the 5 years, or any history of vascular access thrombosis, I would not use these kind of agents.
Thank you, Dr. Meena. So, Arvind, you of course are pretty familiar with all of that, and you are with the activity that you have on various other fora by which knowledge is generated, disseminated, etc. For example, social media. What is the extra bits of knowledge that you have gathered which can help sort of guide the clinical decisions? Have you change your own clinical practice in terms of the use of these various agents in management of patients with anemia in chronic kidney disease? If so, then how? What are the main points that guide your discussion or decision?
Thanks, Dr. Jha, and thanks to both speakers for the excellent sort of information that we got about HIF-PHIs. Now, the extra bits of information, social media, that's something that I'm going to talk about now. And that definitely, there has been a lot of discussion on the MACE events of HIF-PHIs and how they compare with ESAs. Remember, we are comparing with ESAs. We are actually already using ESAs. And in comparison, it is non-inferior. There are a few trials that have shown that maybe there is an increase in MACE events in HIF-PHIs, but this is not actually true when you dissect the study. And this is true of some of the studies that showed an increase in MACE events in HIF-PHIs, where they looked at USA, a group of patients in USA compared to Europe in the trial, and found that USA had asked for a hemoglobin PEG of 11, whereas the Europeans went up to 12. And when you dissected that data between USA and the European counterparts, we found that the MACE events were actually lower in the ESA group. And this is something that has been brought out recently. I think there are other sort of informations as far as the MACE events go, but there is a recent study from, I think, a systematic analysis where Swapnil Hiremat and co were involved, from the NEJM evidence. And this has come out as recently as in August in the NEJM evidence. And they have looked at the comparison between ESAs and HIF-PHIs and proved that they are no different to ESAs when you look at MACE events. There is an increase in cardiac failure as well as thrombotic events, including stroke, and in vascular access thrombosis in a group of patients who take HIF-PHIs when they are compared to placebo. But when they are compared to ESAs, there is no difference. So all this matters. So we look at MACE events as the major problem and decide that we should not use it. I don't think that is proper, and therefore I have started using these drugs. Now, let's look at other sort of effects. You're looking at obviously cancer-related effects. You're looking at let us say cyst, increase in cyst size, and so on. If you look at cancer-related events, you have to understand that when all these trials were looked at, they looked at excluding all patients with cancer, and those who did not have cancer for the past 2 or 3 years, or those who were cured of did not have cancer for the past 2 or 3 years. So there is really no data as such on cancer, because cancer patients were not included. I would obviously not look at using this drug in cancer patients, but this also holds true for ESAs. So you are looking at MACE, I would still consider using HIF-PHIs. I agree, there is no long-term data. We have to generate long-term data, but I would not give up on HIF-PHIs just because of this MACE issue. Back to you, Dr. Jha.
Great, thanks, Dr. Arvind. We have a question from Dr. Tarun Jaloka for Dr. Dinesh Khullar. First of all, he agrees with the concerns that you have raised, but he says that your concerns may be mainly theoretical. He also says that you several times said that there is a numerical difference, but statistically no difference. What exactly do you want to convey? And he makes the point that we definitely need long-term studies. And I think the last bit of what Dr. Tarun Jaloka says there is something that I hope that we can all agree on, that there is a need for long-term safety studies, specifically for HIF-PHIs. As it turns out, in India, we only have one HIF-PHI brand available, which is made by an Indian company, which Dr. Urmila Anandh discussed in her presentation. But back to you, Dr. Khullar, with Dr. Tarun Jaloka's question.
So I think, please allow me to respond before I answer Tarun's question to what Dr. Arvind talked about. I think he has very nicely pointed about what that article in the NAGM has said. But I will draw everyone's attention to the criticism of that article. I can provide that. I don't have the time, but there was a piece-to-piece dissection of whatever was raised in that issue of NAGM, and I think that it makes a very interesting reading. Probably it will change someone's perception. Now, the question which Tarun has asked, Tarun, it's extremely important what you want to know. You say that, yes, we need to keep the two numerical differences segregated from the statistical difference. Well, I think when the real world evidence is not robust enough, it is only piecemeal progression. You would first have numerical evidence, and then obviously, as the more and more data accumulates, you will have some statistical significance attached to it. But what it means is you cannot go away from the fact that there are definitely safety signals attached here. Yes, point well taken, and we need long-term studies. That is certainly what I am repeatedly reiterating. Yes, give me the proof that they're safe. I would want to use them on my own self as well. Very interesting thing, Tarun, since this question has been asked of you, you have actually, and I was fearing Dr. Urmila raising that interesting point about at least decidustat, what it does to the complement pathway, and I think retarding the progression. So I was probably, admittedly, I had no answer, no rebuttal to that. But if tomorrow, apart from addressing safety signals, the drug also comes out with some pleiotropic effects, I'm a game, especially when you say that, okay, it does something to the complement pathway and slow down the rate of progression of CKD. That's an added and a huge benefit. But so far, I am not talking about efficacy. I am talking about the safety. And I think that is what we have been taught all these years. First, look at the safety of a given drug and only then give it to your patients.
Great, thank you. That's a very important point, the one that you made in the end, Dr. Khullar, is that safety is, of course, the prime concern whenever a new intervention is introduced into clinical practice, especially when the efficacy of the intervention is at best thought to be equivalent. But I think we must again remember the point that Dr. Urmila Anandh also made, is that the non-inferiority design was by design, that the trials could have definitely be designed to demonstrate superiority of HIF-PHI so far as the efficacy in raising hemoglobin is concerned. But that's another question which we can discuss at some other point. So maybe we can try to come to some sort of a confusion. But before that, again, there is another question which is a kind of googly for me. Do HIF-PHIs have an effect on the skin? Do they cause bullous skin lesions? Does anyone know the answer to this question?
Well, I think the people have raised a concern. There were a few reports where they said yes. But then I think unless you see a spurt of these kind of similarly looking skin lesions, you can't say that they were related to. We know that there are a lot of skin manifestations which are quite typical of our CKD patients. To say that this happened via HIF-PHIs, I would not be unfair to the drug. And similarly, what Dr. Priti said about PRCA. Now, just one one lot of EPREX injections, and that too related to the cork, the rubber cork of that formulation should not tend to make us believe that PRCA is going to be repeatedly caused by ESAs. And I think we have to put things in the right perspective.
Yeah, but the PRCA story is actually a little bit more complicated than that. It's not so simple as just being due to the rubber compound. But again, let's just come back to the conclusion. I think we all agree that we possibly need long-term data. And even though, Dr. Urmila, you said long-term studies are going on, I wish that those long-term studies are properly designed and have sufficient number of subjects. Doing these kind of studies just for a few months in a few hundred subjects is not adequate. This is something that pharma companies often do as a tick box exercise, that yes, they're doing pharmacovigilance studies or phase 4 studies, but perhaps we as a community do need to get involved in some of these. Whatever be the nature of these studies, they should be supervised by academics, and they should be also monitored by academics for them to be sort of reliable from the point of view of evidence generation. Because ultimately, it is up to the clinicians to be the best patient advocates as we can be. And again, before we draw this discussion to a close, and we can go on for a very long time, I want a comment from all of you as to how do you look at the patient perspective into making these decisions? How do you have these discussions with the patient before you decide whether or not to start anyone on HIF-PHIs? Maybe starting from you, Dr. Urmila Anandh.
Now, as Preeti said, there are patients where we are quite sure that they need ESAs or they need HIF-PHIs. Very small subset. But majority of the patient in my practice, we use HIF-PHIs quite frequently in dialysis patients and non-dialysis. We give them a choice. And whatever little we have about information about MACE and make not much, we give them a choice. And whatever my practice in Delhi for the last 2 years, sir, patients do prefer oral tablets and the costing. They are a little comfortable with the use of these medicines. Patients are informed. We have a consent form we are part of the post-marketing surveillance of Decidustat. And we have now looking into the data, it's almost a year.
So if you have, it would be great if you can share the information sheet
study is
that you
still
use
going
for the
on,
patients.
sir. Yes, sir. We
But
have a small
the information. Yeah.
Because they have a
Dr.
consent
Preeti,
form.
Dr. Preeti, consent form is a different thing.
We have a small information.
No one can make out what the consent form says. It's like the legal document you sign when you download a software, right? Dr. Preeti, what are your views in this?
In my clinical practice, I use HIF-PHIs only in 2 situations. First, if the patient comes back to me and say that I can't use injection first, so I would give them a choice for HIF-PHI, explaining them the side effects. Second, if the patient, after ruling out other causes of anemia, if patient is not responding to HIF-PHIs, in both the conditions, I use HIF-PHIs, not in other conditions.
Great. Thank you, Dr. Meena. Dr. Arvind?
Yeah, so I sort of used HIF-PHIs more often in the non-dialysis population, and this is something I explained to them and say that these are the treatments available. These are the side effects. We don't have long-term data. All sort of information given to the patient, and then if the patient says yes to HIF-PHIs, I do it. If they say yes to erythropoietin, then I would use that. I find that the non-dialysis population tends to opt to take HIF-PHIs. The dialysis population is different kettle of fish, tend to use ESAs more often there. They are a captive population, the dialysis unit, and therefore it's only when hyporesponsiveness or problems with response to ESAs happen, I tend to use it. I must mention that there is a randomized control trial of 150 subjects of renal transplants who've been on ESAs from China. And well, it's very early days, published in June. So no side effects as such, but that's only 3 months down the line. So back to you, Dr. Jha.
And Dr. Khullar, last but not the least.
Yeah, so I think I will certainly want to say that yes, I have also used HIF-PHIs. It's not I've been part of Olympus, Rocky's trial with roxadustat, Ascend-ND with daprodustat, and Dream-ND with desidustat. It's not as if, and I have been using it very heavily. But I would still stick to my point that yes, I'm treading the path very, very cautiously, and always telling the patient, look, they may be a very impressive class, they may have the ease of the convenience, but till the time we have long-term safety data, don't go away, be complacent that they are not going to have any side effects. And I would go back to what I'd shown, that picture of Rohit Sharma with Virat Kohli. So they may be equal big names in their on their respective day. They may have shortcomings, but I think you have to try and see how best to use them in combination rather than pitting them against one each other. So this is what we have to try and devise, and I'm certainly hopeful that all these theoretical safety signals I have pointed out repeatedly do not get substantiated and come in the way of our effectively using. So it's rather than saying pitting one against the other, let's try and see how can we make them complementary to each other in times to come. And then finally, something which we have been trying to do, attempted to do rather, is a combination of the two. So till then, I would again stick to my earlier decision, safety first and then efficacy.
Great. Thanks, everyone. So, Dr. Khullar, I think Rohit Sharma and Virat Kohli are not perhaps the best examples to give in November 2024 right now. You have been following the cricket scene.
Dr. Jha, you allotted this last month when they were at their peak. So I never knew.
So
this
they
was
both are
going
to be on their way out, sir, very soon.
Yeah. So, but in any case, I think the general point that you make is a good one. But what I would like to say on a very serious note is that even though we all are paying lip service to the fact that, yes, we give all the information to the patients and we make the choice in an informed and shared decision-making fashion, I doubt that that is the case in a majority of instances, given how busy clinicians are. So what we should perhaps do is to create a very simple decision aid tool, maybe a one-page tool, which is in the form of a table or a pictorial or an infographic, which depicts the information that we want the patients to get at a glance, so that they can have a look at it, and if they want, they can come back and ask us questions, and then thereby we can make a decision. So I know that we have experts in designing infographics on this panel, and I hope that they will take it up, and that we will perhaps, as an output of this discussion, will be able to bring it out and then share it with the rest of the Indian nephrology community. But again, thank you for bearing with me and staying over time. We have gone 18 minutes over time, but I think it was worth it because it was a stimulating discussion. So thank you, Dr. Khullar, Dr. Priti Meena, Dr. Urmila Anandh, and Arvind Conjeevaram for sharing your wisdom, your thoughts, putting together the slides, and patiently participating in the panel discussion. Thank you very much, and we will share the recording of this with everybody, and hopefully we'll come up with a decision aid tool.
Thank you,
Thank
sir.
you very much for
Thank
the
you very
wonderful
much, sir. Thank
opportunity.
you for.
Really thoroughly enjoyed. Thank you, Dr. Urmila. That was very,
Thank you,
very
Khullar. It was very
fascinating.
nice.
Thank
I
you.
learned a lot.
Thanks.
All right,
So,
and thank you
Priti.
also to Kamal
Dr. Kamal,
and
yes, sir.
NephroPlus for putting together this event and hosting it.
Thank you so much, Dr. Jha, for moderating this and chairing this session. Thank you to all the panelists for joining. Thank you so much.
Thank you, Kamal. Thank you very much.
All right, bye.